the main housekeeping bit. If there are any issues, just do either text me if you've got my number, or Tom, or anyone from the Secretariat, or indeed message privately, but just beware, everyone can see. So I'll be aiming for 45 minutes for the first session, at which point John and Antoine will leave us, and we say thank you, and we'll be joined by Kate Adern, who will be coming for the second bit.
Leila, I was hoping you wouldn't need me right to the end, because otherwise I'm on Zoom for about 8 hours today.
Martin, we are grateful for any time you have to give. So when you feel ready to leave,
thanks.
Just let us know, and we'll say thank you, and you can be released. Ah, hello, Kate. Well, good morning to all for this session of the All-Party Parliamentary Group on Coronavirus. Today we will be looking at the UK's winter plan, but we will also be looking at how we are doing compared to other countries. And so we'll have two sessions, the first focusing primarily on the international comparators, and then in the second session in 45 minutes time, we'll be diving a bit deeper into the UK specific response. So thank you all for being with us. I'll introduce our first panel, and then when we get to the second, I'll introduce whoever's joining us. So we are really delighted to be welcomed today by Professor Neil Ferguson. Neil Ferguson is the founding director of MRC Centre for Global Infectious Disease Analysis at Imperial College London. He also heads the NIHR Health Protection Research Unit for Modelling and Health Economics, and the Jameel Institute for Disease and Emergency Analytics, JIDEA. So welcome, Neil. Thank you so much for being with us. Next, we have Professor Martin Mckee, a good friend of this committee. Thank you for joining us again, Martin. He is Professor of European Public Health at London School of Hygiene and Tropical Medicine. He is also Research Director of the European Observatory on Health Systems and Policies. And in September 2021, he was elected as President of the British Medical Association. Congratulations on the new title. And thank you so much, Martin, for being
actually President-elect, so I take over next year.
All right, President-elect. Thank you very, very much. And congrats again. We also have Professor Antoine Flahaut. Antoine is a Professor of Public Health at the Faculty of Medicine, University of Geneva, where he's the founding director of the Institute of Global Health. So thank you so much for being with us. Vital to have those international comparators today.
Thank you very much.
Thank you so much for joining us. And last but not least is Dr. Jonathan Silas. John is head of the London hubs of the European Observatory on Health Systems and Policies and a senior research fellow at LSE Health. His main research is on health systems, focusing primarily on health financing policy, health economies, and health system performance. He's worked on these topics in a number of countries, including Cyprus, Liberia, Finland, Malta, Mexico, Moldova, Slovenia, and the US, as well as with the European Commission, OECD, and the WHO. So thank you all, four of you, for being with us today. And I hope, as I've made clear from the introductions, we really will not have enough time in 45 minutes to download what we need to from your brains. So thank you in advance for your contributions. I'm going to start just ever so slightly off piste, because I think it would be really helpful to those listening if we could have a couple of sort of setting the scene questions. And so I'm going to start by perhaps, sorry to throw you in it, Martin, but perhaps to come to you and just ask, would you mind outlining how are we doing compared to other places? What is the picture right now globally, and where do we sit in it?
Well, maybe I could just focus on where we are in relation to our neighbours in Europe, because of course there's such a spread, and it's not just where we are at a particular point of time, it's where we are at different stages in the epidemic. And clearly, as we get beyond Europe and North America, there are issues with the data. But in a European context, we're really not doing well. So in terms of cases per million, per 100,000, whatever, If we were a member of the European Union still, we would be pretty close to the bottom in terms of how we're doing. So there are the three Baltic states are doing worse than us at the minute. Romania is doing worse in terms of cases per population, but then we come after that. And we're 5-6 times higher rates than many other countries. Now, of course, there are issues about ascertainment and so on, but even so, we're not doing well. In terms of daily or weekly deaths, we're also not doing well, but we're not quite as bad because, of course, there are some countries like Bulgaria, Romania, Croatia, where there are particularly weak health systems, but we're still in the bottom third. In terms of vaccine uptake, well, we were well in the lead at the beginning, but we have now slipped considerably. So we are running at about 66% or so of the total population. But that's well behind what we're seeing in Portugal with 85%, Spain about 78% off the top of my head. Ireland is ahead of us as well. France is catching up quickly. So in all of those measures, we're not doing terribly well. And even where we were doing well, because we had that brief advantage with the vaccines, clearly we've lost the lead. A particular issue because we had the various delays in the decision to vaccinate teenagers. So compared to many other countries, we're well behind the curve there. So that's a very broad.
That's very helpful. No, thank you. And we're diving into all of those issues, I know, in subsequent questions. And my second question is to Neil. So Neil, obviously everyone very early on was very focused on the models and what we know and what we don't know. And we're entering a period of considerable uncertainty. I wondered if you could help us understand what are the parameters that we need to be really focused on, and what can we not know at this point as well?
So first of all, I'd completely agree with Martin's summary. I think it's a good summary. The one other thing I would add to that is we're uniquely dependent in Europe on the AZ vaccine in terms of the proportion of doses given out. And we know that all vaccines have suffered in terms of a loss of effectiveness against Delta, but the AZ vaccine has suffered more than Pfizer or Moderna, and therefore the key determinant of what's going to happen in the next few months, more than anything else, given that most countries have relaxed most social distancing, is the level of population immunity traded off against the level of contact rates in the population. So compared with, for the reasons Martin said, and because of the mix of vaccines, compared with certainly Spain, Portugal, probably even France and Netherlands, we are behind in terms of population immunity. One interesting thing is that contact rates, as far as we can judge, the contact rates in the population, the things which can lead to transmission, are still well below normal before pre-pandemic levels. And are actually, from the COMIX study, contact rate study run by the London School of Hygiene and Tropical Medicine, are actually probably lower than they were in August of last year still, despite schools having being reopened. And probably the best interpretation of that is that certainly a section of society is still being really quite cautious, and that is helping. So the key uncertainties going forward, and I don't think we're in a position where we can make reliable predictions of what the next few months will hold. The key uncertainties are what will happen to population immunity. We know that it wanes over time. What will happen to contact rates in the population, and then layered on top of that, the effect of seasonality in transmission due to climate, which we still don't fully understand either. It's likely there's going to be upward pressure on the virus, but whether we see I personally think it's unlikely we'll see a very large wave comparable to what we saw in the kind of second wave last year, but we could still see quite a substantial wave of transmission. And I suppose we'll come on to this, but the real challenge will be the extent to which that stresses the NHS. Where capacity is limited. So, I mean, I think one of the reasons we have a high incidence at the moment is these factors, is just the level of immunity in the population versus contact rates compared with our immediate comparator countries.
Mm-hmm. Thank you very much. So if I may now go to Lord Russell for the first proper question, if you like. Thank you for both setting the scene so helpfully. Lord Russell.
Thank you very much. Yeah, this will be directed to each of you in turn. So in terms of COVID-19, what can we expect this winter? And how do you think the UK will vary from other countries? Martin, could I start with you?
Yeah, well, really, I would defer very much to Neil as the modeler here. I think what the experience has taught me is not to predict the future, as it's particularly difficult, because for all the reasons that we have said, we expected that after so-called Freedom Day, there would be a much bigger upsurge. But as Neil has said, there was much less mixing than we expected. People were much more apprehensive and were holding back. And of course, it was better weather and so on. So there are so many unknowns. The one thing I would say, just to add to what both of us have already said, is that, of course, we as a country are going into this in a way that we're much less prepared than many other countries. Excuse me. And I don't know if, I think some of you may have read the report of the Pan-European Commission chaired by Mario Monti that I wrote the evidence or led the evidence review on. And we looked at the reasons why some countries have done better than others. And of course, we have a challenge in this country that our social fabric is really quite weak. We have lots of problems with multi-generational households, poor housing quality, and so on. So all of those create a sort of backdrop against which everything else happens. So, for example, in Scandinavia and Sweden, despite policies that I think are actually wrong, they have many more single-person households. The housing quality is of a much higher level. You've got much more support, less role for the gig economy. So there's all of that. Then there's the resilience of the health system. And, on any of the objective measures, our capacity in the NHS is much lower than most European countries, 4 or 5 times less in terms of intensive care unit beds and so on. So I think in terms of those issues, we have a challenge. Now, Kate Arden will be talking later about the local testing and tracing and the capacity there. And I think it's fair to say, we published a systematic review of lessons from the first wave. We have not covered ourselves in glory in this country in putting a really effective system into place. So for all of those reasons, on top of whatever the virus might do and whatever we might do to encourage it with mixing, I think we've got a weakened social structure and social infrastructure. I think we've got problems with the capacity and resilience in our health system. And I'm not sure that our public health response is as good as it might be, not helped by taking our public health agency and reorganizing it in the middle of a pandemic, which is, as some people might have said in the past, a very courageous decision, Minister.
Neil, could I ask you to give your view, please?
Yes, so as I said in my introductory remarks, I think it is much harder to predict what will happen this year than it was this time last year. This time last year, we had very little immunity in the population. We were seeing a resurgent virus coming into the autumn. This was just before the second lockdown, and obviously we know what happened next. We are in a very different position now. We have high levels of immunity, even if it's not quite as high as some of our European partners and neighbours. I think we wouldn't want to start from here. We're starting with quite a high incidence, so we don't have very much headroom for increases. If we compare, for instance, incidence of COVID cases per day in France, Germany, most, Spain, Italy, and Portugal, they're at a much lower level than those. So they can afford to see something of a surge of transmission, which they may well, without unduly stressing the health system. We are much closer to the limit of what the NHS can cope with. And we'll come on to Plan B. I think that is what is exercising, Whitehall and policymakers is that limited headroom. It is possible, and the modelling suggests we could, and just highlights the level of unpredictability. We could see a continued flat incidence, even slow decline if we get boosters out quickly. So it's not guaranteed we will see a large winter surge by any means. But we can't afford to, at the current time, to have too much of a winter surge before really the NHS is very heavily stressed.
Thank you very much. Antoine, could I ask you to give your response?
Yeah, thank you for your invitation again. Yes, of course. I am completely in line with what has been said. In Geneva, at the University of Geneva, we deliver forecast for 209 countries and territories, and of course the UK and its nations individually. But we refrain to predict beyond 7 days, so I will not be of help for long-term predictions. And I completely agree with Neil. It's probably not possible today to predict much beyond a couple of weeks. So what is sure is that there are a couple of countries which are in much more favorable situation than the UK today. And I will try to maybe mention one country we did not talk about, which is Denmark. I think Denmark, is very well connected in the middle of Europe and is densely populated. It's close to the high level of income and close to the UK in a way, and not high. It's not easy to compare the UK and particularly England with, I would say, with Finland, for instance, or with Iceland. But to compare with Denmark is something possible. And Denmark was highly agile and reactive during the pandemic. If you see the performing, how to say that, efficacy in terms of managing the pandemic, I will use the mortality, the total cumulated mortality rate, which is 45 per 100K population in Denmark, when it is above 200 in the UK. So it's much more performant in Denmark. And their key, they do not use any new tools or any new recommendations you did not use in the UK, but they use them much more quickly than in the UK or even in Italy or Spain or France. They really were the first country after Italy to lock down in March 2020. They were the first country to have an extended use of the Corona Pass, this vaccine passport plus immunity. So, and they were the first one to lift it. Of course, after the UK, I would agree on that, but they lifted when they were in a very favorable shape. So they were sticked with health indicators and agile to free the people and the population when it's no more needed, and to reinstall it very, very soon in the process of the rebound of a pandemic. So I think that is one lesson we could learn from this European country.
Thank you very much. And John, please.
Thank you. And actually, I agree with Antoine. I was going to bring up Denmark as well as the sort of the poster child of Europe, because if you look, I think looking at the, obviously I'm not even going to go out 7 days in terms of a prediction of what's going to happen in the UK, but trying instead to reframe the question around, if we look at peer countries, so similar to Antoine, if we look at peer countries, so countries that have similar levels of immunization to the UK, which would be the ones that have been mentioned. So Denmark, Finland, despite being more rural, Spain, Portugal, of course, much higher, Italy, Ireland. These countries all have, they're much later in terms of lifting restrictions. So Denmark, as the poster child, they locked down early. They had very good. A lot of people were very responsible in following mask mandates. They used the COVID pass, but also by the time that they've unlocked, which was about a month ago, their positivity rate is only 0.5%, and here in the UK we're talking about 3.5%. So if we look across countries that are at a similar rate of vaccination as a share of the total population to the UK, it's really hard to make a comparison because the UK's strategy is so much of an outlier. So, opening up Freedom Day on July 19th, a little more than half of the population was vaccinated. Whereas if we look at these other countries, we look at at Portugal, which is still not fully lifted restrictions, and they're targeting 85%. We look at Spain, which is targeting 75%. Finland, sorry, I had to look at my list to remember the numbers. Finland is targeting 80% of the eligible population over age 12 before lifting restrictions. So, the UK's approach has really been, if you're going to compare to countries with similar levels of vaccination, so countries that are arguably in a similar position in terms of, not including the natural immunity in the population, the UK is really in a much less risk-averse position than the rest of Europe. And if we want to look across the ocean, of course, the US, where I'm originally from, is not the greatest comparator. But if you look at the state of Vermont, so the highest vaccinated state in the US, similar rate of vaccination to the UK, also a very liberal place, very rural, so you wouldn't necessarily expect a lot of contacts and a lot of transmission. But Vermont is facing some of the highest hospitalization rates and the highest case rates that it has throughout the whole pandemic. So it's not to say that that necessarily portends for the UK, but I think that there are reasons to be concerned about the low level of risk aversion of the UK's approach.
Thank you very much. Leila, back to you.
Thank you very much. Barbara Keeley?
Thanks, Leila. Well, I think we've already started on the question that I wanted to ask, but it's mainly back to John and Antoine. The question was, what measures are countries across Europe and beyond doing to prepare for winter in the pandemic, and how does that compare to our plan? And you've already started answering that. Perhaps you could draw out, perhaps what other countries are doing on the point of the vaccination rates, which have been accelerating, and they seem to be making more of a success of that. And other interventions, like mask wearing, so if you draw that detail. Could we start with you, John?
Yeah, sure. So I think in terms of other countries, a lot of countries in Europe have started with vaccinating the over 12s earlier. So before school started, beginning in August, some beginning in July. I think the mask wearing is it's basically the three things I think I would raise to this question are, of course, this point, vaccinating the over 12s. I would also raise the use of a green pass or a COVID pass. So this is a much more common approach. I think this idea of a winter plan comparison. So in the questions, what is the winter plan of other countries? I think other countries don't necessarily have a formal winter plan. Some have an action plan. Finland has an action plan. But most don't have necessarily a publicly available winter plan because they haven't, as I mentioned, lifted restrictions yet. So the things I think I want to point out that are different from the UK's approach in terms of not necessarily their winter plan, but their approach currently and for the foreseeable future are the vaccinating the over 12s, the use of masks. So these are still mandated indoors in most settings in most of these countries. And in a lot of these countries, there's been a shift away from cloth masks to requiring medical grade masks, requiring FFP2s. So in Germany, for sure, this is very common in addition to other places. And as I mentioned, and the use of a COVID pass. So the idea that the so-called the 3 Gs in Germany, which in German would stand for vaccinated, healed, or tested. So this is being used with much more frequency than in the UK. Personally, I have not been anywhere where this has been in use. And I think this is really important because, if we're going to limit super spreader events, of course, it doesn't mean that people are not going to go to these events and potentially be infectious, but they're less likely to pass it on in a super spreader event to many people. So again, vaccinating children, starting with that early, the really maintaining these indoor mask mandates, especially non-cloth masks, and the use of a COVID pass would be my 3 winter plan approaches that I would highlight.
Thank you. Can I come to you, Antoine? Yeah.
Yes, thank you. Thank you for this question. Of course, completely in line also with what Jonathan said. So just to add a few things, again, if we look at the champions in several countries around us, you have some champions for specific things. For instance, Portugal and Spain are the champions for vaccinating the elderly. I think vaccinating the elderly is quite important. Of course, the third dose for them, but the first 2 doses when it is not done. And it is achieved by 98 to 99% of this age class in the Portugal and Spain. And to try to achieve such level is very important. So do not just be satisfied with 90 or 95%. We should go very, very far to avoid any surge in hospitals during this winter. And also the third dose for the elderly seems to be highly important. The second thing is regarding the COVID pass. I fully agree that the COVID pass probably played a leading role, particularly in France, in Denmark, in Italy, to really contain the summer wave very, very effectively. But if you want to introduce that, I don't know about the legislation in the UK, which need to be prepared ahead of time. So I like when France, for instance, decide to extend the potential for using it up to next July. Of course, they have presidential elections, so maybe the parliament will be a bit frozen during the summer, the springtime. But anyway, it's good to have the legal possibility to implement this COVID pass in the future. Maybe also you probably in the UK have a very good example. You are a model for school testing. So continuing the testing in school is very important, assessing it also academically, I mean scientifically. I don't know about your investments in ventilation. My thinking is that since it's an aerosolized disease, we need to focus a lot and to invest a lot in ventilation of closed, how to say that, poorly ventilated and crowded areas where you spend a couple of hours. So typically school classrooms, canteens, and also in enterprise, in companies.
And could you say, Antoine, if other countries are definitely doing a better job on that? Can you point to a country that's doing well on that?
I think Ireland is doing a good work on that, and this is one country which is really dedicated to that. Germany, Chancellor Merkel said that she wanted to invest. I'm not completely sure they have achieved that, but they wanted to invest a lot in ventilation. Yes, CO2 sensors implemented in rooms, in classrooms particularly, are important. Yes, and the masks, but it has been said. Securing the borders, I think you did a good job in the UK in comparison with many other European countries. It's probably easier with the fact that you are an island, but you have done it. Sometimes a bit erratically in terms, not always driven by science, but at least this is something which is securing the border is something which is of high importance when we see the champion countries also in the world.
Okay, thank you. Thanks for your answer.
Thank you very much.
Yeah.
If I could now go to Baroness Brinton.
Thank you very much, Leila. Are other countries taking a prevention or a mitigation approach to this next phase of the pandemic? And I wonder, Martin, if I could start with you, could you just explain the difference, please, for those who may not understand it?
Yeah, well, I suppose prevention is really about trying to drive down the cases, and mitigation is about preventing the adverse consequences, and particularly hospitalization and so on. No, I mean, I think that most other countries, I think the UK is unusual in being, at least in some quarters, being appearing to be relatively unconcerned about the number of cases. And there's a narrative that is developing, which is as long as the NHS is not being overwhelmed, then we should not worry so much. Now, that, of course, goes back right to the beginning. And it goes back to this point about the NHS is at greater risk of being overwhelmed than most other countries because we have much less capacity than many of them. So from that point of view, you can sort of understand where we're coming from. But I think, and difficult to say about them all, But generally, my sense is, and John and Antoine can help me with this, my sense is that as I'm discussing it with colleagues and with John, many of the same colleagues, there is a sense that the UK is somewhat sanguine about the level of transmission that is going on at the minute and the way in which it is moving towards this argument about it doesn't matter so much. And this is a particular issue in schools at the minute. I think there is a great deal of concern among my colleagues about the very high levels of transmission, and also the way in which there is a sense to which, and we saw this with the JCVI statement and other things, there is a sense that people do not want to talk about long COVID. Long COVID is an inconvenience. It's something that it would be much better if it, if we didn't actually talk about it. We minimize it. We find ways of measuring it that make it look much less of a problem than it is. But we can get into an endless debate about the methodology and the definitions and so on. But it is a problem. But to come out with reports that don't even mention it, I think, is problematic. So I think that we're seeing this focus very much on deaths and hospitalizations here. That is a little bit different from elsewhere. And we have the line that we have broken the link between cases and hospitalizations or cases and death. Well, we haven't broken the link. What we have done is we have reduced the ratio of hospital. I mean, this is much more Neil's area than mine, but we've reduced the ratio of deaths or hospitalizations to cases. Of course we have, because of the vaccination, but there's still a correlation.
Thank you very much. We'll come to Antoine next, please.
Yes, in fact, we use an English word for prevention, which is suppression. Suppression means that we do not accept high level of circulation of the virus in the territory. And Denmark, Norway, Finland were really in these policies. And of course, Japan and South Korea also. If you see their epidemic trends, when they go to the top of the hill of the wave, it is usually values we would consider in the UK or in France or in Italy as low tide. So they do not tolerate a high level of circulation of the virus. So what do? They act very, very early in the process of the rebound of the wave. So when you have good indicators telling you that you are in the process of an increase, you suppress it very, very early. And you do not accept this plateau you have in the UK if you are in a suppression policy country. You do not. You try to really reduce dramatically. So you reinstall the path, you reinstall measures which allow you to go very, very low tide. And when you are at low tide, it's much easier to control things, to free the society, to free the population from any measures which are not needed. So to be agile needs to be very early in implementing measures, even strong measures, but very early also to lift them when they are not completely needed.
Thank you. And John?
Thanks. So I think this will, to a certain extent, repeat some things I've said, but just to make the point a bit clearer, in terms of are other countries taking a prevention or mitigation strategy, I think that basically everyone outside of the UK who's at, well, not everyone, but the majority in Europe who are at similar levels of vaccination are taking similar approaches, which is that they are waiting until a much higher percentage of the population is vaccinated, and then they are very gradually lifting restrictions, and they're keeping many things in place, like COVID passes, like masks, with the exceptions of countries like Denmark, who arguably have earned their Freedom Day by having such low case rates and by locking down so early. So I mean, I think, rather than focus on the terminology and whether, is it a mitigation, is it a suppression? Like, I think the way that I would think about this is that most of the rest of Europe that's at similar levels of vaccination is most of those countries are taking similar approaches. They're opening much more slowly. They are maintaining a lot of restrictions in place. And it sort of enables them, I think, to put those measures, more strict measures, back in place if there happens to be a spike in cases. Whereas in the UK, it does seem like there's not so much of a strategy to keep case rates down, that there's sort of an acceptance and sort of a wait and see type of approach, which I would say is more in line with the US than it is with much of Europe.
Thank you. Neil, did you want to add anything?
Not particularly. I mean, the government clearly has said, I mean, it's not really science here, it's just a political judgment that they want to live with COVID. And so we'll come on to it in the next session, that their primary criterion for acting is additional pressure, unstated quite how much, but on the NHS. But beyond that, I mean, I think my colleagues gave a good summary of the situation.
Thank you very much. Back to you, Leila.
Thank you very much. Caroline Lucas.
Thank you, Leila. I wanted to change direction slightly, and I'm just wondering if any of you can help me with my question about global vaccination, because in the UK's winter plan, they do have a section on helping to vaccinate the world. And they say, for example, that the UK has donated around 10.3 million doses to COVAX, and that they are planning to reach 30 million doses by the end of the year. I wonder if anybody could tell me how that compares to what other countries are doing in terms of their donations, whether we think it is anywhere near enough, given that maybe only 2% of people in some of the low-income countries have received even a single vaccination, and also if there is any concern then about a booster program for the whole of Europe that looks as if it's not just prioritizing those who are vulnerable, but basically is being rolled out in a more blanket way. I don't know who to come to, but if anyone could wave if they think they could help to answer that. Thank you, Martin, that'd be great.
Yeah, and no, if I'd known you were going to ask, I would have looked at the numbers. As you can imagine,
Right.
You're working on COVID as well as many other things. There are so many numbers to try to keep in mind. But I think the way in which we've reframed this, we do actually look in the report for the Pan-European Commission. I wrote in the chapter, there's a section on a new global vaccine policy, and you might want to look at that. And that was the sort of collective view of the commissioners, who include, for example, Jim O'Neill, who many of you know. So there, I think what we're saying is that it's not an either or. And we maybe need to move away from this argument. We just need a lot more vaccine. And we need a lot more vaccine to be distributed. And what we don't want are gifts of vaccine that are given to a country a month before they're due to go out of validity. That doesn't really help anybody, particularly when you're giving them to countries that are struggling with their health systems anyway. And I think there's a lot to be learned from what the Global Fund has done. I should declare I'm a member of the advisory board for the Friends of the Global Fund Europe, and we've been discussing that in that forum, where I think the Global Fund has developed a lot of expertise in getting medicines to different parts of the world, and to making sure not that they just get to a national airport, but they get to the people that need them. So there's all of that. Now that really comes down to looking at issues of patent waivers, and as important, what are called trade secrets, which are the know-how, the manufacturing capacity, and an investment in the manufacturing capacity in low and middle income countries. So, we almost need a step change. And what worries me a little bit is the debate about, should we give boosters to older people in the UK or to children or whoever, versus giving it to Africa. It should not be an either or. We just need
it is, isn't it, though, Martin, right now?
Well, yes, I know, but the problem is, by framing it in that way, then we don't address these more fundamental problems, which are that we just need an awful lot more of it everywhere. Because the reality of it is that even if we took all of the vaccines that are being given as boosters in the UK and give them to Nigeria, with whatever the population of Nigeria is at the minute, it's a lot of hundreds of millions of people, it would really be a drop in the ocean. So I think that way of framing it is problematic, and we just need to get a lot more of it.
Thank you. Does anyone else have any evidence about how other countries are doing in terms of donations for the global?
Yeah, I mean, so I just building on that. I mean, the UK actually was quite generous in giving financial donations at the start of COVAX, and I think it's the third largest national donor to COVAX. I would tend to agree with Martin that giving unused stocks of vaccines late in the day is not necessarily the optimal, particularly if they only have relatively limited shelf life, not necessarily the optimal donation. I'm not aware that there is, well, I haven't seen a table of donations of unused doses. I think the biggest problem COVAX has suffered this year is that it was very dependent on manufacturing capacity in India, which basically, stopped. Indians, understandably, given their wave of Delta infection, prioritized vaccinating their own population, but that had an enormous impact on the number of doses available through COVAX. I think lots of countries could have done more. I wouldn't particularly single out the UK as we've probably been better than most high-income countries, but clearly there is enormous inequity globally in access to vaccines. The last thing I would say, the continent which has the lowest coverage is sub-Saharan Africa, clearly. It also has the most limited local manufacturing capacity for vaccines. But also many countries have suffered from the difficulty in putting in place logistics for delivering population-wide vaccination at scale. High-income countries have invested almost as much in that infrastructure as in the vaccines themselves. And in the absence of well-developed, say, primary care and healthcare systems, a lot of countries have really struggled. They've been able to vaccinate urban populations, but getting out into rural areas has been much harder. There are exceptions, but that has been part of the challenge.
Thank you very much. Unless Antoine or John want to say anything, I'll pass back to you, Leila.
Thank you very much. Lord Strasburger?
Thank you. Good afternoon. It's clear that some countries have a markedly higher burden of COVID mortality than others. Perhaps the biggest global difference has been the approach taken to timing and intensity of restrictions, testing and social distancing. Is the UK government taking too much of an inward-looking approach to COVID? Are we learning from the experience of other countries? Neil, would you like to go first on that?
Sure. I think Antoine and Martin referred to, historically, looking back on the pandemic, the principal determinant of mortality has been the timing of interventions relative to the stage of the epidemic reached in a particular country. And that explains certainly nearly all the variation seen across Europe in the first wave of transmission. I think a lot of countries, frankly, were much too slow in acting in the autumn of last year. I wouldn't pick out the UK uniquely. Clearly, there are some countries like Denmark and others who acted promptly, but a lot of the big nations in Europe acted rather slowly. We were unfortunate, let's say, in them being the home of Alpha, where Alpha originated. And so our autumn to winter wave accelerated a lot faster. Faster is the wrong word, earlier than seen in the rest of Europe, where we were exporting cases. And so whilst by December of last year, going into the January lockdown, we did act to contain spread, I think other European countries saw what was happening and acted again earlier in their alpha wave in the spring of this year. Almost similarly with Delta, we were the worst affected European country with Delta. It was seeded earlier into this country at a higher level than any other European country, and that's why we saw so some of these things are misfortune, let's say, and I think I'm being much more content with the timeliness of interventions, let's say since about December of last year than previously, but still it all comes down to timing.
Thank you. John, have you got anything to say on this? I would say I've got one more
question
when we're running out of time.
I'll be very brief, just to reinforce what Neil was saying. We've looked across Europe as well at not so much the calendar date of when lockdowns were imposed, but how many cases and how many deaths. And obviously there are differences across countries in testing, but you can take that into consideration. This is where a country thought it was in the beginning of the pandemic when it decided to lock down. And if you plot these on a scatter plot against each other, the UK is all the way out here, especially England. There were about 2 deaths per 100,000 population at the time in England when the first lockdown was announced. And in many of these countries, Ireland, Denmark, Norway, there were no deaths yet. There were just under 10 cases per 100,000. So I think the timeliness really, if we look across countries at the date of where we were in terms of cases and deaths on the dates of lockdowns, the UK is far out. That's my short answer. Sorry.
Thank you very much. The other two panelists, do you want to contribute?
We don't have much time, but I think this is actually something that would merit an entire discussion session on its own. There is a real problem with our ability to get information from elsewhere. Now, obviously, many of us in our wearing our academic hats do have individual contacts, but we've had, I think, too many cases of where communication has broken down. And I might use as the example, whenever the UK put France on the Amber Plus list, and that was a puzzle to many of us. And I immediately dropped an email to Antoine, and we worked out together that, in fact, this was a mistake. It was a mistake of how the data were read, because the individuals involved, we deduce, I mean, we can't be absolutely clear, but it seems very likely that they were unfamiliar with the database, the way the data were being presented. And but the problem about it was that in earlier days, somebody here below ministerial level would have had a contact in the other country and been able to talk to them. And as Lord Ricketts has described as well, in this, he's been very concerned about this too, former ambassador to France, of course. We've lost those contacts. And we've seen that in so many different areas when we're out of step with the rest of Europe, but there isn't a mechanism for getting on the phone or whatever to talk to somebody, or meeting them in the corridors, even on Zoom, or having the mobile phone numbers of their counterparts. And of course, there are many individuals, and I'm sure Neil has many contacts, and other people have personal links to Christian Drost and other people like that across Europe, but that doesn't seem to be happening at official level. And partly that's because I am told, and others will no doubt be able to give you evidence, there's a view that contacts for political reasons should be largely at ministerial level.
Thank you. And Antoine, do you mind if you give us a quick answer, or hold until I've asked the next question?
Yes, very quickly, just to say, if you want to learn one lesson, is not to hope too much on vaccines. It seems for me that in the UK, you are relying on vaccine, which is quite excellent. You have an excellent vaccine production, you have an excellent coverage, but maybe not relying only on vaccines. So those countries like Singapore, with 80+% of coverage, are experiencing a wave, even with a surge in hospitals beds, and even with mortality. So it may happen this winter that we may need to combine measures and not only to rely on vaccine for lifting measures, for instance.
Thank you very much. And my last question is about daily case numbers, and we've talked about it a bit already, but we can't escape the fact that Britain is pretty well top of the league for daily cases, new cases per million of population, and something like 5 times the level of the EU. So how have we got there? What have we done? What's the main thing that we've done wrong to get to the top of that rather unwanted league? And does it matter? Martin, would you like to go first?
Yeah, I think I've maybe already answered that. I think it does matter. I wrote a piece for the BMJ recently where I said, have we given up? And it wasn't just about this, it was about relaxing our rules on putting untreated sewage into the water supply. And it was about relaxing the rules on testing for HGV drivers and other things, where many of the public health measures that have been put in over time, we've sort of we've retreated from. So I personally think it does matter. And I think part of the problem, as I think we've already said, is that there's been a focus on the mitigating, protecting the NHS and not worrying so much about cases.
Thank you. And John?
Yeah, so I think to answer your question about why we've gotten here, I think it has everything to do with the fact that we lifted all restrictions at around 50% of the population vaccinated, and really no one else in Europe has been doing this. In terms of does it matter? I think if you're looking at 30,000 cases a day and about what one in 30 of them end up as a hospitalization, it might not matter so much now for the NHS, but I think it probably will in the winter. I mean, thinking back to prior years pre-COVID, the NHS really struggled with seasonal flu, and so I think it doesn't take very many additional cases, even if you have weakened the relationship between cases and severity. If 1 in every 30 or 1 in every 40 cases is being hospitalized, and you're getting above 30,000 cases, 35,000 cases a day, and people also they're not going to the hospital for a day. They're being admitted and they're staying and they're on oxygen for many days. So I think I think it matters. I think that eventually there will be a lot more pressure on the NHS.
I think you're saying this is not a good way to start the winter.
It's not a good way to start it. It's risky. I think, having opened in mid-July, we're, I guess, a couple months ahead of some of our peer countries. So I think we're the canary in the coal mine as opposed to some other country.
No, thank you.
Can I just add something to that? I mean, so I might give a slightly different view. Case numbers started accelerating really in May into early June before we lifted all measures, and it was entirely down to Delta. If we wanted to reduce case numbers, and in the Euros as well, that was again before we had Freedom Day. I mean, the response at that time of the government was to delay the final relaxation of measures by a month. But it wasn't really, and this is more politics than science, I mean, it wasn't really on the agenda to go into reverse to suppress case numbers. So we were unfortunate in getting Delta early, and it took longer to seed into other countries. But I agree, fundamental, we've ended up here because of basically a policy to live with COVID. In terms of hospitalization, I do think it is a key metric. It's more like a 1 in 50 ratio now in terms of cases translating into hospitalizations. Also, the protection against death is much higher, and protection against admission to an ICU is considerably higher, provided by vaccines, and seems to be sustained. So those ratios in terms of cases to hospitalizations are larger if you talk about the more severe endpoints of ICU admission or death, and so there's less stress at that level. People also appear to be staying in hospitals for less time if they are hospitalized than they used to. So it's a complex picture.
Thank you. And Antoine?
No, I have nothing to add. I think all the things have been said.
Thank you very much. Back to you, Leila.
Thank you very much. Baroness Brady.
Good afternoon, and thank you for your time and candour today. What I would like to ask, please, is what do you think is the most important thing the UK government can do now to ensure the pandemic is brought to an end as soon as possible? And I'd like to start with Neil, please.
So I'm not sure if you can easily, first of all, I mean, this is a slightly semantic point. I'm not sure it's easy to define the end of the pandemic. And we're moving into a time where COVID is becoming endemic in all countries of the world. I think the key issue is what does one do to try and reduce the health impacts of infection. So coming to the European example, I completely agree with Jonathan and others that, I mean, they have demanded a higher threshold level of vaccination coverage in their population before lifting all measures than we have. But nevertheless, if we talk about going to next year or whatever, there will be continued COVID transmission across Europe. And at some time point, we're going to stop relying on social distancing measures completely. So I think if we're talking about the end of the pandemic of being, when can we move out of the emergency situation in relying on non-pharmaceutical interventions, on social distancing, on test and trace to achieve control, to entirely relying on vaccination, then the number one thing the government can do is increase vaccination coverage, increase booster coverage, put 2 doses into teenagers rather than just 1, and ensure population immunity is as high as possible. I personally think for the next few years, we are going to see seasonal surges of COVID transmission, which will challenge the health system on top of flu and everything else. Healthcare capacity probably will need to be, well, we know that anyhow, healthcare capacity will need to be expanded to better cope with seasonal surges. Whether we need for some years to come to rely on some degree of mitigation beyond just vaccination remains to be seen. So it's a long-winded answer. There isn't a simple answer to that question.
Thank you for trying, though. Martin?
Well, I'm very tempted to quote the Prime Minister and say, if you will pardon the expression, prenez une grippe, because I think having a really well worked out strategy, which was clear and had I mean, we will be maybe coming on to talk about this later, would help. You know, I think it's wrong to think there's a magic bullet. I would just throw in ventilation in its broadest sense, ventilation, filtration, and all the other things on top of other things. I think that's the one thing that where we're really lagging behind at the minute.
Anton?
I would say if we want to end the pandemic, we need to think globally and not only locally. So the UK is probably one of the countries which has done the most regarding the vaccine coverage, the global vaccine coverage, when and at least I would say the University of Oxford and AstraZeneca dealt with the Institute of Serum of India, which is the biggest producers of vaccines in the world. And with this co-patent deal, they are able to produce a lot of vaccine for humanity. Unfortunately, they had experienced this wave of the Delta variant in their country, and they stopped export to Africa. But our duty now, and maybe the UK may be a major country to push this duty, is to implement facilities, factories everywhere in the world. I mean, in each continent, at least, in each WHO region, I would say. We need that Africa is self-sufficient with regard with its production of vaccines, of treatments, of diagnosis, which is not the case today, as it has been mentioned. So maybe, you know, it's not a new issue. In fact, the COVID-19 had helped a lot to speed the process. Before the COVID era, it took often 10 years before a vaccine was distributed in the North country, in the rich countries, and after to the low-income countries. So now it is not 10 years. It will be probably 1 year before the coverage is sufficient in Africa, if we are optimistic. But 1 year is much better than 10. But nowadays, we may think about, I don't know, global public goods, a list of essential drugs, vaccines, diagnosis, which needs to be produced without any patent, or maybe with affordable prices in each continent. And the UK can play a leading role in the international and multilateral organization for promoting that.
Thank you, Anton. And John?
Thanks. So very quickly, to echo Neil, I agree. I think that increasing the rate, the percent of the population that is vaccinated is crucial, and focusing attention on the 12 to 15-year-olds as well as boosters is very important. I think also it's probably worthwhile to try and change the narrative a little bit. So moving not from what Anton was talking about a more global perspective, but a more local UK perspective. I think prepping the population for the eventual possibility of a shift from plan A to plan B is probably worthwhile. Plan B looks a lot like plan A in the rest of Europe. And I don't think that there's a lot in plan B that's so dramatic. It's much more just, mask mandates, and it's not the same level of lockdown that we had much earlier on. So I think, really improving this communication at this stage that the pandemic is not over is probably will help to soften the blow if we do invariably move to plan B at some point in the winter.
Thank you all very much. Back to you, Leila.
Thank you very much. Well, thank you all. I have run considerably over time in this first session, and I thank in particular John and Antoine for staying with us. And apologies to Kate, who now joins us, for being a bit late. I'm sorry, Kate. John and Antoine, you are very welcome to stay. If you don't wish to, you don't have to, but you are of course very welcome. And Martin's already indicated in advance that he may have to drop off at some stage. So just let us know, Martin, when that moment comes, and we are always grateful for your time. So just let us know how long you've got. So I'll move now to session 2 and introduce Professor Kate R. Dern. Kate is Lead Director of Public Health for the Greater Manchester Combined Authority for Health Protection and Planning, Emergency Planning and Response. And that's in addition to her substantive post as Director of Public Health for Wigan. So thank you so much for joining us, Kate. Really appreciate it. And as I said, thank you so much for your patience as we came to you. But I hope you can see a lot of it was weaving very, I think, neatly in to what we're going to be focusing on now, which is that UK specific response. And at points, I know that we've all been sort of itching to ask and answer those questions. So let's get into it. So Kate, I'll ask you a question that I think others have kind of already started to answer before, which is in terms of COVID-19 in this country, what's your expectation of what we can expect this winter?
I think it's going to be a very challenging winter ahead for a number of reasons. Obviously, in places like Greater Manchester, we have areas of enduring transmission and high underlying prevalence. So, for example, the case rates at the moment range from just over 500 in Stockport to over 300 in our borough. So that's very high if you think about cases per 100,000. And if you add on to that the backlog in terms of non-COVID ill health, particularly related to long-term conditions in areas like Greater Manchester, where there is a high level of underlying health problems, respiratory, cardiovascular in particular. You then add on the potential for a bad flu season, and we are still, unclear as to how bad flu will be. Clearly, we're watching the patterns from India as opposed to Australia and New Zealand, where we normally look to for the predictions for our winter. But yes, that's potentially very challenging. We're already seeing outbreaks of respiratory syncytial virus, particularly amongst the sort of older end of children. And of course, we have norovirus as well, which is highly unpredictable. So I guess, listening to Neil, to Martin, I think it's very, sort of unclear as to what winter will be like, but we are planning very extensively for outbreaks of flu in care homes, and clearly the rates of COVID will be very problematic if they tip the system over when it's trying to recover from the backlog of other conditions. So yes, a very challenging few months ahead, I think, for us, particularly in places like Greater Manchester, who've experienced, I have to say, 4 pandemic waves, not 3. And it's very important to stress that there are parts of England that have actually had considerably worse experience of COVID to date than some other areas.
Kate, just as an aside, here in Oxfordshire, I know we are essentially preparing for the NHS to become overwhelmed. In fact, it's already happened a couple of times, albeit very briefly. Are you taking the same approach? The likelihood is it's going to happen. It's a matter of when, not if.
Yes, I think one thing that's very good about our system in Greater Manchester is that the 10 boroughs and the health and care system, of course, we have a degree of health and care devolution in Greater Manchester, which is unique to Greater Manchester in the English context. And that enables us to operate all of our hospitals as a single system. So there is mutual aid going on across all of the trusts in Greater Manchester, and that's around the ICU capacity, but ordinary bed capacity as well. So that does enable us to have some flex and some support within the system, and it creates a much more resilient system. So in spite of some of the challenges we've had, and clearly Northwest Ambulance Service, like another of our ambulance services across the country, have experienced significant challenges. What we've been able to do is to mitigate quite a bit of those challenges in terms of the health and care system through our excellent mutual aid arrangements. I think I would also echo the points that we've seen that the vaccination programme has certainly reduced the severity of ill health within the COVID admissions. So we've seen COVID admissions go right down and length of stay for COVID go down. But also we have also seen a dramatic drop in mortality since the vaccination programme was undertaken. However, what we have seen since May, June is our admission rates plateau at a high level. So it would not take much in terms of increases in COVID cases over the next few weeks and months for the system to tip. So yes, that's what we have to plan for. And of course, we have to recognise that we do have a higher prevalence of these other conditions that put challenges on our system.
Thank you very much. Baroness Masham.
In your view, does the government's winter plan allow for the speed and intensity required to prevent the NHS being overwhelmed, should that be the case? And I would like to add, have we enough NHS trained staff? And if not, what should we do? Could we have Kate, please?
Well, perhaps, Baroness Masham, obviously I work for a local authority, not the NHS, so I'm probably not the right person to ask that particular question to. But I would sort of add that, just perhaps give it a slightly different context. Response to COVID is a whole societal, whole system response. It's not just about the NHS capacity. It's very much around social care capacity as well, and the ability for us to provide support from local public health systems. So this is where my role as a Director of Public Health and the ability of my team to respond very rapidly to control outbreaks and clusters and to bring transmission rates down is absolutely critical. So we support, of course, our NHS colleagues in terms of the rollout and implementation of the vaccination programme. And indeed, without local government, it would be difficult to do things like mass vaccination because, we provide some of the logistical support to that. So for me, the winter plan needs to actually allow folks like me to get ahead of the curve, recognise when outbreaks and clusters are happening and be able to deploy full mitigation measures, be that being masks, testing, contact tracing. All of those kind of measures are really important, and also to help us target the rollout of the vaccination programme. So that for me, it's another bit of the system that tends to get hidden, but actually without that, without those preventative measures, then that's going to tip over into admissions and pressure on the health and care system. So you also need plenty of contact tracers and local public health teams, as well as NHS trained staff.
Working together must be essential. Could we have whoever's left, please? Is Neil still here?
Yes, I am. So, I mean, I don't work for the NHS, but taking the first bit of the question, so I think the winter plan is a template. It doesn't specify exactly when different escalation of measures will take place. There's a lot of work underway in government at the moment involving academic groups such as my own and many others, in terms of putting some more flesh on the bones, in terms of answering directly those questions. How quickly will we need to act? I think lessons have been learned. At the moment, we're running at about 600 hospital admissions a day in the UK due to COVID. I think if we saw that double, then that would be the sort of level where we would need to be thinking about moving to Plan B. And it's really the trend. The lesson we have learned is that if you start seeing an upward trend, and that's sustained for a period of time, then you need to get ahead of it, because any action you put in place will take 2 to 3 weeks to have any impact on hospital admissions. So those are the things being discussed at the moment. I should also say, it's not a precise science in predicting what the impact of, for instance, encouraging working from home again would be, or mask mandates, or vaccine mandates or passports for particular venues. And so it is a imperfect thing. The general thing we can conclude, though, if we see a sudden and rapid upsurge, we will need to respond more intensely than if we see a gradual increase. And I strongly suspect that therefore measures would be adapted to the circumstance we find ourselves in. The worst case, of course, would be, which we can't rule out, it's difficult to even judge the probability, would be the rise of a new variant which substantially escaped vaccine-induced immunity and the protection from vaccines. We can't say, I think personally it's unlikely, but beyond that, it's difficult to say. But clearly if we saw, and I think the Winter Plan states this, if we saw that happen, then measures would almost certainly need to be more intense than if we saw a gradual, slow but sustained increase in case numbers.
Thank you so much. Who else have we?
Martin?
Yeah, I'm not sure I can really add to that, to be perfectly honest. I think it was pretty comprehensive.
Fair enough. Okay, thank you very much. Can I go to Barbara Keeley?
Thanks. Well, I think more questions around the point that Niels has been talking about with the winter plan. He's just described that it doesn't specify when escalation will take place. There's a question really about the data triggers that we've got. And I'm particularly interested, Kate, in your perspective, because you described to us that you've got cases at 300 in your borough and 500 in other parts of Greater Manchester. And that it sounded to me as if you needed some local triggers, if you like, so that you could move into preventive measures. Now, the winter plan, well, it seems sketchy, doesn't it? But it's presumably around cases, hospitalizations and deaths. But we've heard that we're behind other countries on, dropping mask wearing, behind on ventilation. So to Kate first, what can be done in a situation where we've got uncertain triggers, and you need, it sounds like you're going to say you need local triggers or local way of doing things. I mean, I'm sure we wouldn't want to get back into local lockdowns, but what would you want for public health?
I think I'm going to refer to the excellent work that we've done in Greater Manchester on schools escalation, and indeed we have developed a schools escalation plan, which goes from basic measures through to what we do when we've got multiple outbreaks. So I'll give you an example from my own borough at the moment. We're dealing with an outbreak in one of our high schools. So I've brought back in face mask wearing, not just in communal areas, but also in classrooms. And, we're looking at, we've done PCR testing of over 600 students in that school, found another 16 positive cases, reinstituted and advised on lateral flow tests for sibling contacts, for example. Things that break the chain of transmission are really important. And the reason I've picked that example is if you have, high rates of transmission amongst our 15 to 19-year-olds, which is particularly the challenge at the moment in Greater Manchester, then what you actually do is put, unfortunately, a delay in those individuals being offered the vaccine. Because if you test positive for coronavirus, then unfortunately there is a 28-day delay before you can receive your vaccine. So there's a disruption, with a school-based vaccination program, that actually puts a delay in offering and rolling out the vaccine. So, it's very laudable that there is a national target that the programme for 12 to 15-year-olds needs to be completed by half term. But with the high transmission rates going on in that age group, then that pushes a real delay in that programme being delivered. So there's an unforeseen consequence and a knock-on consequence, of course, on school nursing services who are delivering it and the school IMS providers. So that's why, being able to put in place, mitigation measures to actually bring transmission rates down would actually assist us getting, really sort of getting that vaccination program rolled out as quickly as possible. So that's why we need that sort of local flexibility to be able to do that, both in settings like schools, but also where we've got, potential high transmission rates across broader cohorts of the community. So it might be a demographic as opposed to a geographic set of measures.
Thank you. Thanks, Kay. Neil or Martin, have you got anything you wanted to add to that? I know we're running short on time, but the national perspective isn't enough in its own, is it? How do we get?
I think again, the government has said that it's not going to move to locally adapted measures. That's a political judgment. I think there are pluses and minuses of doing so. I think the key, coming back to the issue of what are the thresholds and what are the key metrics, the Winter Plan is clear that the number one metric is NHS demand, particularly hospital demand. And I think that is sensible for the reasons I've stated earlier, that the protection against death, protection against ending up on a ventilator offered by vaccines is higher than the protection just against hospitalization. So hospitalizations and overall hospital occupancy is going to be the key stress point going forward. I think, I am hoping, I'm even say optimistic that lessons have been learned from last year in terms of the need to act promptly if we start seeing a sustained increase in hospitalizations.
Thank you.
I might just add one very brief comment, because I will have to go now, but one of the things I think it's important that we don't do is to look at the NHS in isolation. Because we know that we have a very complex society in which so many things depend on one another. And if we are going to have fuel shortages, if we're in this situation where ambulance drivers are being written to ask them if they would reorientate to become HGV or fuel tanker drivers, if we are in a situation where care home workers are being poached to work in the retail industry or elsewhere, all of these things can unravel very rapidly, as we saw in the last week. And I would hope that whoever is in charge of contingency planning is looking at these networks and these interrelationships, because the whole nature of a complex system, as Neil knows very well, is that your starting conditions are important. You have non-linear relationships and you've got feedback loops, positive and negative. And that means that you can, a challenge in one area that may seem unrelated can very rapidly cause considerable problems.
Yeah,
but with that, I will.
Thank you, Martin. And of course, we do have potentially losing 40,000 care staff. And as Kate said, it's not just about the NHS, it's about social care as well, because the staff are not vaccinated. Cool. Okay, thank you. Back to you, Chair.
Thank you very much. Well, thank you very much, Martin. If this is the point that you're leaving us, really appreciate your time as ever. And thank you so much for that, for spending extra time with us in the second session as well. If I could now please come to Baroness Brinton.
Thank you very much. What impact will the UK's third dose and booster programme have on case levels? And will this be enough to prevent further non-pharmaceutical interventions this winter? And I ask this especially in light of the advice to the clinically extremely vulnerable who were formerly shielding, given that all the advice to them has been scrapped, and even the HSE advice to employers has been scrapped, so that anyone who is clinically extremely vulnerable can and indeed have been asked to return to work in an open plan office with no ventilation.
Right. Shall I have an initial stab at that one? So the data is, we have two sources of data. One is immunological, where there's a lot of data on what booster doses do to antibody levels. And that looks very promising, irrespective of the first two doses of vaccine you've received, which they were. If you get a third dose of, say, Moderna or Pfizer, you go up to antibody levels which are considerably higher than even achieved immediately after the second dose. And that would suggest a very high level of protection even against Delta. In terms of the direct evidence of the effectiveness of booster doses, there's really only data from Israel at the moment. quite a nice study, but it doesn't give an absolute measure, indicated that after the third dose of Pfizer, comparing people who got a third dose of Pfizer with people who hadn't and had been vaccinated some months ago, they saw a 10-fold reduction in the risk of mild disease. And so that's encouraging. I mean, so that would include probably asymptomatic infections and just people who are mildly ill, probably an even bigger reduction in the risk of hospitalization. So that would, I mean, there were some caveats. You talked about the clinically extremely vulnerable population. We know some of those groups respond less well to vaccines. So you might not see quite the level of protection in the general in those groups as you would see in the general population from a booster, but undoubtedly a booster will almost certainly boost whatever level of protection they have. As to what impact it will have on case numbers and therefore transmission is much harder to say. I mean, the strategy, vaccine strategy has been quite cautious in recent months, as other people on the panel have said, and we are only rolling out booster doses to those over 50, basically in exactly the same order as we did the first 2 doses. So we're starting from the oldest in society and the clinically extremely vulnerable, and nobody will get a booster dose sooner than 6 months after their second dose. What that's going to mean is most of the booster doses are going to be coming out from late this month through till about January, February of next year. So they will have an impact, and they will have a bigger impact on transmission as more and more people get them. But our modelling would suggest it will be somewhat limited. What it should do, though, is more directly reduce healthcare demand to some degree. We know that about half, a bit more than half of people being admitted with COVID into hospital at the moment have had 2 vaccine doses now. Much smaller proportion of those dying, but they're still getting admitted. So it will reduce that demand. Of course, it can't help with the people who haven't been vaccinated at all, but it will still nevertheless have an effect.
Thank you, Kate.
Thank you. Obviously, I'm not going to add to Neil's excellent scientific evidence about the booster dose, but the couple of points I would like to make is that whilst we are rolling out the boosters, and that's very important to do so, I would point out, for example, in Greater Manchester, 27.9% of adults have yet to receive 2 doses. So we're still rolling out the primary programme, and there's significant inequalities and variation in that. So, for example, that ranges from 32% of adults not fully vaccinated in Manchester through to 13% in Stockport, so one of our wealthier boroughs. And what we are seeing is the highest case rates correlating with the populations and the communities with the lowest vaccination uptake. So absolutely concur with Neil that it's critical to get the vaccination programme out to reduce the risk of admissions. And of course, where you've got people who are clinically extremely vulnerable, in contact potentially with the unvaccinated population, that clearly increases the risk. So it's perhaps just a little reminder that we haven't actually got the primary course of the 2 doses of the vaccine fully out to all of our adult population. And if I give you just my own local range of this, if I look at the clinically extremely vulnerable who are vaccinated in my borough, that's 94%. So that's fantastic. That is, WHO herd immunity, 97% over for the over 70s. But that drops right down to 54%. And this is good actually in the 16 and 17-year-olds, and 17% in the 70% in the 18 to 29-year-olds. So as you go down the age ranges, you've got lower uptake at the moment of vaccination. And clearly, if you put that together with limited restrictions in terms of face coverings, ventilation, which I agree with Martin is incredibly important, and social distancing, then clearly there is the risk for asymptomatic transmission to more vulnerable individuals.
Thank you very much. Thank you, Neil, as well.
Thank you very much. Baroness Brady.
Can I just cut in and say, I really only have 5 minutes at this point.
Yes. I'd like to ask an opinion before I ask my question. When I asked you all on the one thing the government could do, I think you all agreed it was vaccinate more people. And we've heard evidence that being vaccinated dramatically drops the rate of mortality, the severity and admissions. And yet we keep hearing, Kate was just telling us how few young people are having the vaccine. What, in your opinion, can we do to encourage more young people to have it? And why do you think there's a reluctance? Kate. Maybe Neil as Kate.
Sorry, I'm back on. Thank you for that. I think there's a number of things. Interestingly, obviously, we're only just starting with the 12 to 15 rollout. I think clearly there is a lot of vaccine hesitancy and information, anti-vax information out there, which clearly needs to be robustly addressed, but people's concerns addressed as well. So, it's getting people who have influence with young people as opposed to necessarily, older middle-aged professionals like me doing it. One of the things we do in Greater Manchester is actually a lot of insight work. So we work directly with the communities themselves, and we produce, and it's publicly available, monthly insight data. So it's going in and actually talking to those communities. Who are the influencers? Using young people themselves being the influencers of uptake is really important. One of the things we've seen with our 16 to 17-year-olds locally is they actually bring their parents along. So sometimes it's actually the teenagers who are pulling the parents in. So there's a mix. I think it's using all sorts of good forms of communication, not just posters and leaflets or old-fashioned things, but it's good old-fashioned word of mouth, and trusted relationships are incredibly important. One of the things we've found, over the last 12 months, and I've been operating a highly integrated contact tracing system across Greater Manchester. What we get back from that is local voices, people they trust, who they know, who have that ability to communicate in the language that people understand. So it's really important to ditch some of the professional language, if you like, or the techie language, and actually relate and communicate in one-to-one type of engagement. And that's incredibly labour intensive, but it's the way my colleagues in Bolton, for example, when they were doing surge testing, also addressed vaccine hesitancy through that. And it was that one-to-one engagement that actually makes the big difference. So let's sort of, I guess it's reminding that locally relevant messaging, using locally relevant individuals who have the influence are really important.
Thank you, Kate. Neil, I don't know if you have anything to add on that.
Not on that one, no.
Thoughts, because I know you're leaving. If you've got anything you want to leave us with.
No, I mean, I think, the points just made about the challenges of increasing coverage, I think entirely valid. I'd also just add that it couples to other strong, levels of inequity in society. We see greater vaccine hesitancy in ethnic minorities than in white British people. And greater hesitancy in frankly, poorer income quantiles than richer ones. In terms of thoughts to left with, I do think we need to prioritise, at the moment, for instance, 17 and 18-year-olds have only had one dose. And we need to, I think, be a little less cautious in accelerating vaccine rollout, in particularly second dose rollout in teenagers where possible, because we know that one dose of these vaccines against Delta has a really minor impact on transmission. It's only after 2 doses that we start seeing a significant impact. And whilst I think I'm of the view that data supports that vaccines do benefit young people directly in reducing their very low risk of infection, and that benefit outweighs the very rare side effects which have been reported on, partly because COVID probably causes those same conditions itself, and all young people will get infected with COVID if they're not vaccinated. But we need to accelerate those second doses coming into the population. I'd like to see us be a little bit more probably aggressive in rolling out booster doses as well, because the sooner we can, the sooner we will reap the benefits of that. And I think the data supports that it's not just after 6 months, probably after 4 months after the second dose, you'll still get a very big effect of booster doses.
Well, thank you very much, Neil, for joining us today. Really, we massively appreciated. Thank you so much. And just to round us off with just Kate, but Kate's immense knowledge, so absolutely worth doing, is Lord Russell.
Yes, Kate, you said a lot about the importance of sort of local knowledge, local networks, local infrastructure, and the flexibility that brings. But do you feel you and your teams have the data you need to make the right decision? And will you feel as on top of the UK government seems to feel it will be in trying to see whether we are going to need to move from plan A to plan B?
I think in answer to your question about data, I fought that battle 12 months ago, particularly around contact tracing data and access to patient identifiable data, the sort of data that I have access to for other communicable diseases. And I think if there's one reflection I would give you, we've tended to treat COVID as though it's different to other communicable diseases, and in fact it isn't. The same kind of public health measures, the same approach to outbreak management and control that we do for other communicable diseases is just as applicable to COVID. So I do now have the intelligence, and indeed, we had to fight long and hard for that, but we now have that through our Power BI systems. And if we couple the kind of statistical intelligence we get from national sources, and there is no reason that granular data that's available to national stakeholders should not be available to stakeholders in the local system like me. You know, we are well used to handling confidential information and doing it using it very successfully. But what we have to also couple that with is our local knowledge, our qualitative knowledge of communities. So one of the things that's really important to understand is how people travel about, who they link in with, that social and physical geography, and how infrastructure is organised. So, you know, from my own borough, we don't tend to socialise with people on the eastern side of Greater Manchester in places like Rochdale and Tameside. Wiganers tend to socialise with people from Warrington, St Helens and the south part of Lancashire, the rugby league boroughs, as I would call them, because that's where traditionally people went for, go for their sporting tradition and their social communities. And it's been interesting throughout the course of the pandemic to watch my borough's figures mirror those of the boroughs that communities actually socialise and have family ties to. So that kind of local intelligence doesn't appear in national statistics, but it's the kind of intelligence people like me gather in a very systematic way to help us make those decisions. And that reflects in things like the weekly tracker we share with my population, and also the kind of updates I give on my fortnightly live Facebook Q&A sessions. So it's a mix of national intelligence and national data sources through the JBC, the Joint Biosecurity Centre, but that has to be set alongside the excellent local knowledge of the demographics, the traditions, the heritage, and the social contacts that we have in the local system. It's not an either or. You've got to have both parts to put the jigsaw together.
But Kate, so the local knowledge that you have, I mean, you've managed to extract painfully national data. Is there a reciprocal flow of the type of rich local data you're talking back to the centre, and is that working?
Yes, I think it is working much better now. It wasn't working so well, when things started off, but certainly in terms of, regular brief, we regularly meet, DPHs regularly meet with the Chief Medical Officer on a fortnightly basis. We meet with our colleagues from Contain, and also now we've started in Greater Manchester meeting with our national test and trace colleagues at a national level on a regular basis, and that's very important. I think often, again, a reflection, the knowledge, expertise and experience in the local system. I mean, I've got more than 30 years experience of managing outbreaks, for example, and the way in which the local system operates in a multi-agency approach through local resilience forums. And, we haven't mentioned those today, but the approach to emergency planning and response for a big kind of enduring incident like a pandemic really requires that kind of multi-agency LRF strategic coordinating group response to coordinate all sections of society, be it, the police and trading standards to help us with compliance, but also the support around businesses, so working with our business sectors to get out good advice and support. It's not just health and care or a public health response, and I guess that's really important to understand that expertise in that local system. And also, it's very difficult, I guess, sitting remotely to understand a borough like Wigan unless you live in it, or a system like Greater Manchester unless you are there and they're experienced in it. So it needs to be a sort of joint decision as opposed to an imposed top-down solution. It doesn't work. So you need that freedom and flexibility to adapt within a national framework, the measures and the, if you like, the approaches that best fit our communities. So it's not an either or, you have to have both.
Thank you very much, Kate.
Can I just come back to Baroness Brady, who I do apologise I skipped her question, but actually it's a very important question in the context of what you're saying. Baroness Brady.
Yes, the government has highlighted the importance of test, trace and isolate on their plan. How do you think it's working? Could there be any improvements?
Well, I've been operating an integrated contact tracing system across Greater Manchester since June 2020. And we set that up with the now UK Health Security Agency, obviously Public Health England, with all 10 boroughs in Greater Manchester and our Greater Manchester Health and Social Care Partnership. So it was NHS, PHE and local government. And we have operated in a way that has performed at a 93% success rate. The other thing we've done, very importantly, and I think if a reflection on perhaps the way the national system was set up, separate programs for testing and tracing. And actually you have to have testing, tracing, isolation support, and of course vaccination all working together rather than separate siloed programs. So I think perhaps a criticism of the national approach was setting up separate, very siloed systems that didn't really interact with each other, whereas on a local level, we've been operating as a single integrated approach. So, for example, in terms of contact tracing, we've successfully completed over 4,400 complex settings in that period, and 2,000 index cases, and traced over 300 VOCs and VUIs. Now, in setting up that kind of approach, what we've been able to do is also mutually aid each 10 borough, for each of the 10 boroughs, support the local contact tracing teams, have single approaches in terms of what we do in educational settings, businesses and workplaces, train a lot of, so we've actually created quite a few jobs through doing this, to have surge capacity in our contact tracers, who are now being trained actually to do flu risk assessment as well, and broader infection prevention control. So what we've got is the beginnings of a local health protection system that can be taken forward into the future, because I guess, again, one of the things we should be doing is not building a response just for COVID, but thinking about what does the health protection system look like for the future, that can respond to future challenges. And I guess very big expensive programs are not going to be the solution to that. Having resilience in the local system, contact tracing hub, just to give you the cost, it costs us 1.5 million for 12 months to operate. So in terms of sort of, effective use of resources and being able to spread that workforce across other challenges, you can then flex it back into COVID response should you need it. That's the kind of investment we need to see, I think, rolling out across the system. People who can multitask across a number of different areas, but can support COVID response, it might be TB response, it might be flu response, all the way through a local health protection system. So that for me is the prize, if you like, to take the lessons from COVID and actually build back a much better, more resilient system. So we're not in the situation we were perhaps at the beginning of this pandemic, where we had not enough boots on the ground to actually do the job.
Thank you very much, Kate. My final question is more for you. It's a wish list. What would you like Boris Johnson in his speech tomorrow to announce that would palpably make your life easier now, or would help you sleep better because they're on the right track? You get 3, pick them wisely. What would they be?
Okay, number one is, I think, confirmation that we are going to get continued investment in local health protection systems beyond March of next year, because the COVID money runs out next March. So everything I've described in terms of what we've put in place to successfully respond to COVID in Greater Manchester, this highly, a high-performing system, would not be able to operate unless we have the resources to do that. So very important to see that recognised, particularly in the spending review. I think, secondly, I would echo the point about maximum flexibility in the vaccination programme. We need to get that out as fast as possible, and therefore we need to remove things that potentially deflect from that rollout. So really important to have multi arrangements in terms of the delivery of the vaccination programme. So make sure we've got as much access to that as possible. I would also agree with the point about giving a second dose to teenagers. I think that is also important, but obviously I would defer to SAGE's and JCBI knowledge on that. And thirdly, for me, I think a recognition of the importance of not doing things purely in a top-down fashion. I think for me, linking in COVID response and the lessons from COVID into things like the National Resilience Review of LRFs, and building back a really strong, flexible and ability to be rapidly deployed health protection response is going to be key going forward. So UXAR is great, but it's on its own can't deliver that. It's got to have the deployment of the multi-agency response around it to respond to these kind of challenges. This is my 3rd pandemic, so COVID will not be the last. And I guess we need to really build back a more resilient system, which will actually cost us less as well.
Brilliant. Well, thank you so much, Kate. Thank you to all of our parliamentarians and everyone watching. I do apologise if I haven't gone over, but it was such a knowledge-rich session. I do hope everyone forgives me for doing so. So thank you all. Have a wonderful afternoon and stay safe, everyone. Thank you so much for all of your time. Take care. Bye-bye.